This is a case of submaximal angioplasty for emergent management of acute basilar occlusion, a patient with symptomatic intracranial atherosclerotic disease. The patient is a 59-year-old who presents to the emergency room with headaches, nausea, vomiting, dysarthria, and right-sided weakness. Has prior history of CVA with hypertension, hyperlipidemia, on aspirin and Plavix, and has known severe posterior circulation intracranial atherosclerotic disease. The patient rapidly deteriorates in the emergency room, unresponsive, comatose, not following commands, withdrawing to painful stimuli, and requires emergent intubation for airway protection. CT perfusion study shows severe posterior circulation hypoperfusion with markedly increased volume and transit time. CT angiogram reveals mid-basilar critical occlusion versus stenosis. Diagnostic angiogram that was previously performed 2 years ago noted critical stenosis in the mid-basilar. At that time, this was treated through maximal medical therapy. We use a large bore guiding catheter into the vertebral artery, and an angiogram reveals complete mid-basilar occlusion with very slow flow through collaterals through perforators. An 014 wire over an 017 microcatheter at this point is brought through the lesion, and the lesion is crossed into the delayed roadmap, suggesting that we are in the PCA. Over this 014 wire, a balloon is advanced and slow inflation is made in the segment where we previously knew this patient had intracranial atherosclerotic disease. Again, inflation is 1 atmosphere every 30 seconds, with deflation 1 atmosphere every 15 seconds, so we have nominal pressure. The balloon selected here is a 1.5 millimeter by 9 millimeter gateway balloon. Postplasty, we note restoration of flow into the distal basilar. At this point, we feel that the patient's flow has been restored, and we elect to treat him medically. Patient does have some small infarcts in the left occipital territory, but the brainstem is preserved.